Thank you very much. For those of you who don't know what GNP Plus stands for, GNP Plus is a global network of people living with HIV, which is a global network that connects people who live with HIV around Europe. And to be a part of GNP Plus, the person needs to live with HIV. So I'm a proud mother. I'm a proud woman living with HIV, and I'm a proud woman who uses drugs. And I happen to live in Amsterdam right now. I would like to talk about. Well, I was asked to talk about addressing structural barriers, and also about human rights. And the way I would like to do it, I would like to. I don't want to talk about the barriers per se. I would like more talk about a few ideas that I have, and the community of people who live with HIV have, and the organization AHF Europe I work with have. I would like to base my talk on a few principles. The first principle is the right to life, and that each of us who sits here in this room, but also everyone who lives with HIV or does not know or knows about the status, has a right to life. And right to life means access to treatment, first testing, then being linked to care, and then getting access to ARVs. I would like also to base the speech on respect. I think we very little when we talk about issues connected with people who live with HIV. We very rarely use the word respect. So respect to being who you are, respect to being who you want to be, and also respect to choice, and choice to have treatment, to be on treatment, choice to have quality treatment, and also choice, if you are not ready, not to be on treatment. And then the last thing, what I strongly believe in, is that one has a moral responsibility to disobey unjust laws. And I think if we don't disobey, so we are also a part of the group that create the world that we don't want to live in. So if we don't disobey, it means that we support the laws. And well, I do not have any conflict of interest, but what I hope, why I'm doing this speech, I hope that during the speech, at least one of the ideas will be, which I present, will be exciting for you, and maybe you will give a thought to it. So this is my conflict of interest. First, ways we do things, because I work in Europe and also in Eastern Europe, and today and yesterday a lot has been said about the US, but also a lot has been said about Africa and low-income countries. And how I see it, I think we, well, of course we all struggle for the quality of care, but I think that the pictures that we create in terms of the healthcare setting and how it should look like, it's different in low-income countries and then in high-income countries. And very often, unfortunately, for me personally, I think that the things connected with more humanistic approach are much more often present at the left side in low-income countries than in higher-income countries. Well, of course, we live in the world we live in, and we know that the repression endangers the fight against HIV. And we all know, and we talked today and yesterday about different legislations that affect how the world looks like, and also what it looks like for people who live with HIV. But I personally think that what happens is actually covers a few issues that we don't really talk about, which is poverty, literacy, deaths, different, well, there are different causes of deaths, but also corruption, and then also misuse of aid, misuse of funds. And I think what is very important, we need to address the laws that have been that are unjust, but I think what is also very important, we need to uncover the real issues that are in the country, because without this we can't move very far. And of course there are a lot of things that we need to fight against: criminalization of HIV transmission, coerced testing, because till now, till today, there are stories, we hear stories that many people, especially that who come from key affected populations, are rounded up, are being tested without the consent, and loss of no confidentiality for those with, it's not, I hate the word, but with contagious disease, and also treatment. How we treat a person who lives with HIV. In some legislations, a person who lives with HIV is a second-class citizen. And also, of course, people who come from key affected populations, so people who use drugs, sex workers, migrants, prisoners, and I didn't include all of them. I did not include transgender people, street children who do not have any rights, people under poverty lane, etc., etc., and of course criminalization of drug use and sex work. But I think within this context we need to think what to do, how to address the issues, and how to be as skillful as possible to get people tested, to know their status and start treatment. So now a few thoughts. I strongly believe that community-based testing performed by lay workers, trained testers, is one of the ways to go. Of course, we can't exclude GPs, hospitals, STI clinics, but community-based testing in high-income countries and low-income countries suits the purpose. I believe that rapid test as a diagnostic tool, also in clinics, would speed up the process when we want to know that we want to have more people to know their status, and also will reduce the cost. Of course, the question is what about lab workers, but there are so many diseases that we need to deal with, so I think they will not be unemployed. Well, the next question, the question what to use, because, well, especially in higher income countries, the Western blot is sort of a stumbling block for rapid testing as a diagnostic tool. So fourth generation rapid test, the question is, maybe we should forget about Western blot and use the fourth generation test, especially for, I think right now we should use it for MSM community if we want to get to people who are recently infected. And of course, all this will need the change of legislation, and it does not happen. It does not happen very quickly, and that's why we need different people, different stakeholders, people from different walks of life or walks of life to work on this. And then traditional comprehensive model, and we deal with people who are drug dependent, poor. There is a lot of fear towards the system, low self-esteem. So the traditional model is determined by the length of comprehensiveness, is determined by the length of clinic specialist roster. I think what we should think of is, and many people have talked about patient-centered comprehensive care. So getting social support, peer-to-peer interventions, rapid testing, outreach work, case management, and then it will help out with getting to the specialist. I would like to share with you a story from Kazan, from Russia. No, I have my own supply. So, this is actually a clinic that was started by a few crazy doctors who wanted to create a patient-centered care. So what they did, they got a place from municipality, and how it worked. As you can see here is the place for people who came, waiting room, receptionist, and receptionist was the starting point into care, a nice space to see and relax. And then you can see here also a patient's room, as not like in an ordinary setting, you have specialist rooms. So here what they did, they create a patient's room that the patient came to one of the rooms, and then the specialist, depending on the need, and then it was taken care by the receptionist. The specialist went to the patients who needed their support. And actually the story was very successful. They've been doing it for almost 2 years, and they wanted even to publish a fantastic paper. But then the healthcare center, that's the other healthcare center, municipal healthcare center, realized that many people simply get to this center, and they thought that there is a threat, so they closed down the clinic. I would like to share with you also the work that has been done by Treatment as Prevention Working Group at IAS. So this is work in progress still. So this is it's called Concise Guidance for HIV Healthcare Providers on the Use of Art for Prevention, and you can so the poster actually is presented here. And the content of the guidance is still under development of the group, but the core principles are focused on respect. So core principle number 1 is focused on being honest and open, and act with integrity. Listen to the person who comes for care, providing clear and true information, no abuse, coercion, discrimination, judgment, and working in partnership with a person to respect their choice. I think what is also very important in the in the dynamic between the person who comes to the clinic and healthcare provider is that we are often seen as patients, which is we are seen as patients, which means that we don't have much to say, and we are not really agents of change. And I think if we really want to change something, and if we want more people, more people to get into care, we also need to think about changing these dynamics. I think also, in many settings we have good sort of relationship between healthcare workers and agents of change. But I, from my personal experience, I remember, because I lived in different countries, also in Eastern Europe, and then I moved one day to Copenhagen, and then when I went to my doctor, and she shook hand with me, so I was completely in tears, because I was thinking, okay, I live with HIV, I use drugs, and she's shaking hands with me. It means that, okay, she's telling me, all right, I'm here with you, I'm on the same page, I'm supporting you, whoever you are, whatever your needs are. And so I personally think that if we want to move things forward, we need to have a global campaign, global shake hand campaign. And of course, in many countries, shaking hands exists, but in many it does not. And a sort of oppressive environment in the healthcare system exists. I also think that the language matters, and I personally, we use the word stigma and discrimination, which is very negative, but I think if we really want to change the the situation, we need to give an answer to the situation that we have now. We need to talk about respect and respect to the person, to choices, and also a little bit about more positive. We need more positive language to deal. Wait, I'm sorry. No. Whoops. Yes. Then another thing, I believe that we need test and treat approach, but we need test and treat approach with human face, and that's what I was talking about. And one of the ways to do it, I think, is by involving communities in service provision. So of course, we as the communities of people who live with HIV, we are involved in advocacy, we are involved in meeting stakeholders, but less we are involved in testing, and also in many places we as people living with HIV or community at large or lay workers can't provide testing. And then even more rare is having clinics. Well, there are a few examples. There's an example in Indonesia, which is a clinic run by MSM and for MSM. There is Ashar Society, which is a network of clinics for people living with HIV in Bangladesh. And there is also Linda Clinic in Estonia that tries to provide care for people who live with HIV there. But I think we as the community, we can fight, yes, we can fight for this, but what we need really, we need a sort of change of thinking in the medical setting, in the I think we need a revolution. We need a revolution in thinking how we are providing the services, and we need the and this revolution needs to be done by medical professionals, by the Society of Medical Doctors, Nurses. Separation of power. Okay, do I have 1 more minute? Okay, all right. I think what is, very shortly, I think what else matters. I think that having things together like, all right, universities, clinics, but also youths engaged in so students engaged in changing the situation is very important, and this is actually one of the models in Vellore in Tamil Nadu, where this exists. And then the other thing that is important is policy change. So gender balance, I think, is also important, but I think also the youth population, if you look at the numbers of people who live between the 15 and 24 years of age, if you look at the percentage of people around the globe, and then also in different continents, I think that we are underestimating the power that is there. And I personally also think that the age between 15 and 18 is really underused, because at the age of 15 in most of the countries, a person can give consent to sex. But what about perception about healthcare and being involved in the response? And the last thing I would like to mention, this is the European Action Plan for HIV and AIDS, and we were to reduce vulnerability and remove structural barriers in accessing services. Unfortunately, it did not happen. It did not happen at the country level. There was no push. So I think what is very important, and this is my last thought, is the social responsibility that we all have. And this is actually, this is the Kiva approach, which is a very similar, well, sort of similar approach to what Jupp Lange was presenting yesterday. And this is simply sharing the wealth that you have personally, from person to person, supporting people. And this is actually, these are the four, a few women that I personally support through microloans, to that they are able to build their small words and be more empowered. So I think this is the way to go. And if you are interested in Kiva, so please let me know. Thank you very much, and thank you for all the thoughts from my friends.